Hi, welcome to the webinar on the National Survey of Early Care and Education. Today we'll be talking about defining type of care in the NSECE. I'm Rupa Datta at NORC at the University of Chicago. I'm part of the National Survey of Early Care and Education project team, and I, with my colleagues, will be walking us through this webinar today. The objectives for today's session are to define the types of care, and you'll see TOC in the slides a lot to give your eyes a little break. So we'll define the types of care in each of the 3 NSECE data files. We won't be talking very much about the workforce survey today. We will highlight similarities and differences in types of care across the data files. This is perhaps the greatest emphasis for today, is understanding how these types of care crosswalk or don't across the NSECE data files. And then we'll highlight a few research questions that could be addressed across the various NSECE data files having to do with type of care. Mostly to whet your appetite and give you some examples of how you might think about things. Begin with an overview of the NSECE design, and then we will describe how the study approached type of care, which is a little bit novel and hopefully gives you many different opportunities to fashion your research as you wish. We are going to spend a good bit of time on the types of care in the household survey, and so that we're set up to discuss the overlap of those types of care with the types of care in the 2 provider surveys we'll discuss today, the home-based and the center-based. And then, as I said, we'll discuss some research questions that one might pursue. We've left time at the end for questions, but we also welcome clarification questions throughout. Just use the chat function to the presenters, as Jill mentioned. So the National Survey of Early Care and Education was sponsored by the Office of Planning, Research, and Evaluation in the Administration for Children and Families, which is a Health and Human Services entity. Our federal project officer at OPRE is Ivelisse Martinez-Beck, and we also work closely with Anne Rivera and Elizabeth Shui. As I mentioned, I'm the project director, Rupa Datta. We had a fabulous team in the design and the main implementation phase of the NSECE. We could fill many, many slides with the names of all of the people who were critical to that effort. We've mentioned a few of them here. The principal investigator was Bob Gerga at Chapin Hall. We had 3 co-principal investigators, Ann Whitty, Lisa Janetian, and Rick Brandon. And then the data files and the documentation that continue to live on and hopefully are resources to you, those were put together at NORC by a large team led by Jill Connolly and Carolina Malesi. And then we also had people at Chapin Hall, Child Trends, and Impact. And they continue to be knowledgeable about the data if you have a chance to consult them. So the design, the key purposes of the NSECE were defined by some policy needs as well as some research needs. At the time, there were no comprehensive national data about the supply and demand for early care and education, and that was the first priority. Because we're interested in supply and demand, it was essential that we could connect parental needs and preferences to the availability of providers that they could actually access. And so the question of actually connecting the supply with the demand and not just having national estimates about the 2 things separately was a key motivator. To achieve these, we undertook 4 different studies. They're all interconnected. The first is the household survey, which profiles all families with age-eligible children in a location. And we say location, the NSECE has a focus on communities, and so we sampled communities about whom we could talk about both their demand in households as well as the supply. And so the word location in this case is referring to communities, and we wanted to be able to profile households within those communities that had age-eligible children. We also wanted to be able to document the care that was available in those communities. And that includes center-based care to children not yet in kindergarten, as well as home-based providers to children all the way up to age 13. In addition, we sought to characterize the early care and education teachers and caregivers, including individuals working in center-based settings. And then finally, there was a great emphasis on describing place-based aspects of child care provision and use, and this is the notion of community and various measures of supply and demand. And so I just went through these 4 surveys that we conducted to meet these policy needs. 3 of them we'll talk about today: the households, the home-based providers, and the center-based providers. The sample approach is relevant to understanding our mission today because really a lot of our focus in today's webinar has to do with how you might generate comparable estimates between household and home-based data, for example, or if not comparable estimates, at least estimates that connect to one another in a meaningful way. And so it's helpful to understand where the samples actually came from. So there were 2 primary sample sources for the NSECE. On the household side, we were looking simply at housing units all across America, and from those housing units, we identified households with children under age 13, and they made up our household survey sample, as well as home-based providers to children under age 13. And we call these home-based providers who come from the household sample, we call them unlisted providers because they come straight from households. They're not known to state or national entities as child care providers. In contrast, we also had a provider sample source, and this was built from state and national records and many other sources to identify all center-based and home-based providers of early care and education to young children that we could map and list. The center-based provider survey comes from that sample of state and national lists, as does the portion of the home-based provider survey sample that we describe as listed because they were on these lists of state and national providers of EC. We do have a variety of analytic products that describe these different populations, the center-based providers and the home-based providers. And in those documents, we explain more about what these different sample types might mean and provide some basic descriptive information about those groups. We're not going to talk about it today, but from the center-based survey, we also identified workers who work in those centers directly with children, so teachers, assistant teachers, aides. And the workforce survey is a sample survey of the 1 million individuals working in centers as in those teaching capacities. Just as an overview of sample sizes and reference populations, the household survey includes 11,629 households with children under the age of 13. Since we collected data on all children under age 13 in those households, we have 21,665 children under age 13 in the household survey data. They together represent almost 30 million households with children under age 13 and about 50 million children. And so those are 2012 numbers, which is when the data collection took place. In the home-based provider survey, again, you see the listed and unlisted distinction that I made on the prior slide. There were 3934 listed providers. So these cases represent 121,000 listed providers to children birth to age 13. In addition, we have another 2,052 cases of unlisted providers. Those individuals serve 5 million, represent 5 million unlisted providers to children birth to age 13. You see there's quite a big discrepancy there. We have about 4,000 listed providers, and they're representing 121,000 providers, whereas the 2,000 unlisted cases in our data represent 5 million unlisted providers. We have household survey, a sample representing about 30 million households and 50 million children. We have home-based provider data representing 121,000 listed providers and 5 million unlisted providers, with 8,300 cases in our center-based provider sample that represent 129,000 center-based programs serving children birth through 5 years, and then classroom-assigned workers. And in that case, we have 5,500 workers representing 1 million classroom-assigned workers working with children not yet in kindergarten. So previous studies, previous to the NSECE, we found many different taxonomies for how type of care was created. For example, referring to home-based care, we see terms like family, friend, and neighbor, family daycare, and group home. And often these terms have slightly different definitions across studies and data sets. They may overlap, or they may even sometimes be mutually contradictory. The same thing happens in center-based care, with Head Start being considered either a funding stream or a program type or a type of center. There are words like daycare or nursery, which sometimes have specific meanings, and others are more general and vague. Faith-based preschool is another construct that we see at different times defined in different ways. As you look across the literature, it can be quite difficult to plan future work and understand how to implement these definitions. So the choice that we made for the NSECE was to not adopt any specific taxonomy for the NSECE. We, of course, have to have some sample definitions so that we can implement the study, but beyond that, our aim was to be as flexible as possible so that many of the most common definitions used in policy and research and practice could be implemented within the data sets. And so we talk about these as elements of types of care. So we tried to collect the building blocks of how different types of care definitions were constructed so that researchers could implement whatever definitions they chose, given the available building blocks. And one thing that's useful to think about, since we're talking today about how well the household types of care match the provider types of care, a really important concept is what respondents can actually tell you. So if you think about it, respondents may know or be able to tell you different things that would be useful in a type of care definition depending on their role in the system. So a parent may not know if her home-based provider is licensed or not. At the same time, providers may not know household income. Providers may know which child gets a subsidy or is funded by a particular funding stream, but in that case, although they know it, their ability to report it may be limited because you'd have to collect a great deal of excruciatingly specific data in order to get child-level coverage by funding stream. And so when we think about these elements that we collect, they're largely driven by what would be useful, but what also is feasible to collect at high quality from respondents of different types. So some choices of definitions have been used in the NSECE analyses that we've made available to date, as well as in the creation of variables that we've made available on the data files. And so some of what I'll be talking about today are types of care choices that we've made as a project team, and that if they are acceptable to you, you can use very easily because the variables have been constructed, there are explanations in our analytic materials about how they work and what they mean, and so they may be a very useful first choice for you. At the same time, you as a researcher can go back to the raw elements that we collected and construct a different definition. And we want to help you understand what's available and what those choices might be. Although we did build in a lot of flexibility, you'll also want to keep in mind that what you can actually use for your analysis doesn't just depend on the individual variables that exist in the data file. In some cases, the individual variables may exist for a type of care you'd like to define, but there may be relatively few cases in our data that meet that definition. So you may not have enough sample size to conduct an analysis, even if the definition itself can be implemented in the data. Similarly, with the listed and unlisted distinctions in the home-based data, and some other statistical considerations may play in that constrain how much flexibility you have in the analysis. So those are sort of three different concepts that it's useful to think about. One is I'll be telling you about choices that we've made. The second is I'll tell you about choices that you theoretically could make. And then the third is that you will need for any given analysis. If you want to construct your own types of care, you'll need to explore the data to see whether it's actually feasible to conduct an analysis using a certain definition, even beyond whether or not the definition can actually be constructed within the data file. And we might have some examples of that along the way. All right, so we'll begin with types of care in the household survey. So the provider roster is a construct that we have in the household survey, where we began by asking the respondent to enumerate all of the individuals or organizations that cared for their children under 13 in the prior week. And about each of those providers, we asked a set of questions. And this then list of provider roster variables is a list of elements in the lingo that I've tried to introduce. So these are individual constructs that we have. We'll then talk about how the team has put them together, but you could certainly put them together in other ways. And so we begin by understanding whether a provider is an organization or an individual. If an individual, did that individual have a prior personal relationship with the respondent? Prior to the interview, did the respondent provider have a prior personal relationship previous to the care being delivered? If it's an individual provider, does that care take place in the child's home, in the provider's home, or in another location? For organizational care, we asked about single-type activity providers, and so this might be a tutoring program, it might be gymnastics lessons, particularly for school-age children, but also at younger ages, we see some use of lessons and activities, both for enrichment and for childcare. And so single activity providers are a separate category. Drop-in care, where there is no previous enrollment list, but you can, go by for a session at the park district or the library, or maybe at the gym. That is another variable that we have. Whether or not the provider is paid to provide the care to this child, whether this organization is a regular K through 8 elementary or middle school or not. And then we have a special meaning of the word regular when it comes to child care arrangements in the NSECE. Regular means that an arrangement occurs at least 5 hours per week. So that child receives care from that provider at least 5 hours weekly. That makes it a regular arrangement. If the care is less frequent, fewer than 5 hours a week, or not necessarily each week, then we classify it as an irregular arrangement. There are additional variables that we also used for type of care coding, or that you might use. We had something called a provider lookup. So as I mentioned in an early slide, we built a list of lists. So we constructed a sample frame of every center-based and home-based provider of early care and education that we could identify on state and national lists. The primary purpose of that sample frame was to draw the center-based and home-based listed provider samples, but we also made that list available in the household survey interview, so that when a household survey respondent told us where their child went for care, we were able to look it up in the sample frame so that we have address information about that facility and access to the other information in the administrative lists about that facility. For example, whether the facility is on a Head Start list or is also an elementary school. In addition, we used contextual information about programs such as maps, internet searches, directories, things like that. And then we also used contextual information about the child and household. For example, the age of the child, the income of the household, things like that. So an infant could not be classified as attending a regular elementary school, no matter what the respondent said. So these are all additional elements that appear to greater and lesser extent in the data files that are available to you, mostly depending on what we can release without violating disclosure. For example, if we consulted a map of an area to look up whether or not a center was located at a particular address, of course we would not be able to make that available to you, but what we have made available in the data file is a variable that says, yes, we were able to confirm this location for this provider. A few of the key variables that we have in the household survey a set of variables called type of care, and these loop through up to 12 providers per household and up to 9 children per household. That's what the _X_Y tells you. So there are 9 times 12 of these variables for each household, and they describe a set of detailed type of care categories for each child provider pair, and we call that an arrangement. I'm going to rush through most of this information. We did a few months ago conduct a webinar on data about ECE arrangements in the NSECE, and if you're interested more in these topics, I would encourage you to look up that webinar on Research Connections. In addition, we have an aggregated type of care variable, which has 10 standard categories and facilitates analyses because many of the detailed type of care categories are quite sparse and difficult to analyze separately. And then the two BP quality flag and BP source flag refer to those additional variables that I was just talking about, things like consulting maps and directories, how well we were able to confirm that the arrangement reported by a household does indeed exist in the type and place that was described by the respondent. Okay. So from these elements, we constructed an aggregate type of care variable. So I'm now shifting from the elements that I described, which are available and you kind of can't change. We asked what we asked. What I'm now going to talk about is what our team has done with those types of care variable, with those elements. You could combine those elements in different ways to construct an alternative set of type of care variables, and we hope you do. But what I'm going to describe for the moment is what we have done, some choices that we made, and then that will follow into the discussion of how these map to other surveys within the NSECE family. And so for this, as I mentioned, we classify regular versus irregular care, and so regular arrangements are ones that take place at least 5 hours weekly. And the first 5 aggregate types of care are regular care arrangements. They begin with 3 individual types of arrangements, and there are really 2 factors that we take into account. One is whether or not there was a prior personal relationship between the provider of care and the child. And the second is whether or not the provider is paid for the care of this child. And from those 2 characteristics, we develop 3 categories. The first is an individual provider who had no prior personal relationship to the child and is paid for the care of that child. The second category is an individual who did have a prior personal relationship with the child and is paid for the care of that child. And the third group is individuals who provide unpaid care to a child. There is no prior and no prior here, since, as you can imagine, it is unlikely that someone had no prior personal relationship and yet is providing regular unpaid care to the child. So these are the three individual categories we have. And then we have a category 4, center-based early care and education, which covers all centers that serve children up to 72 months, that not in drop-in care, not single activity care. And so here we tried to match as closely as possible typical definitions in licensing and other contexts. And so Head Start, public pre-K, community-based childcare, most of what we think of as center-based early childhood falls into this category. And then we have the last category, which is also organizational care, and we call it other organizational early care and education. It includes any regular organizational care that's not in the center-based category. So that would include after-school care to children under age, after-school care to school-age children, drop-in care, single activity care, many of the things that I mentioned in the provider roster, and neither of these includes elementary schools. Again, this must occur at least 5 hours weekly. The regular care arrangements are the ones that we know about the most information. So we have information on costs, hours, and many more aspects of the provider relationship than we do for the irregular arrangements, which are now on the other non-parental care slide. And so here we have a category for K through 8 schooling, which we don't necessarily think of as early childhood traditionally, but one of the purposes of the types of care here is to be able to fully enumerate everything a child did in the course of the prior week. And of course, many, many children under 13 spend a lot of time at elementary school. And so it's important for us to have that category to account for children's time. Irregular ECE is one of the categories that is much more fully fleshed out in the detailed types of care. It is possible to distinguish between irregular home-based, irregular center-based, and different other aspects. But for our analytic purposes, we have combined them into a category called irregular ECE. And then we unfortunately have an all other settings unknown category for a very, very small fraction of arrangements that have where we simply were not able to code information, but fortunately they are very, very few in number. Okay, I think that this might be a good time to take a few questions. We have a few more slides about households, but I wonder if we have any questions before that.
We do have a question. Someone asked, would family care typically fall under individual? Does family care equal home-based care?
So by family care, I'm guessing that we're thinking about things like a family daycare, so small home-based or perhaps large home-based care arrangement that serves unrelated children. And yes, the centers are perhaps the easiest way to think about it is that home-based is in physical locations that are residential, so somebody's home, whereas center-based and organizational care takes place in non-residential settings. We'll talk more about how family daycare might get further classified within home-based, but as a rule, family daycare and anything that takes place in residential facilities will be classified as home-based care. Were there any other questions, Jill?
There were no other questions at the moment.
And this is just an illustration of the types of things we do. This is not just the individual types of care that I just described to you, but actually the combinations that children might have. And so first we have the regular care arrangements. And for example, in the first row, we see that 5% of children 0 to 35 months had only an individual provider with whom they had no prior relationship but who was paid. And in the next row we see about the same, 6% who had only an individual paid provider but with whom they had a prior relationship. Part of the point of this slide is for you to see some of the combinations lower down among the regular care arrangements. So it is possible, for example, to classify children who have one arrangement that's coded as an other organizational ECE arrangement and another arrangement with an individual unpaid provider. So the variables exist for that kind of classification to be implemented. However, you see in the table that combination, other organizational ECE and individual unpaid, covers 0% of children in our sample. And this is just an example of the types of constraints that you might encounter, even if you're able to define something that you're interested in some cases, you'll decide that the sample doesn't meet your needs for other reasons. Of course, if you are interested only in doing that subgroup analysis, what rounds to 0% in this table may still be a couple of hundred children. And so depending on what you do, you may or may not be able to take a look. Okay, so one question that we get a lot is, why did you track all this non-parental care? And so as you can see from our aggregated type of care list, we have irregular care, we have elementary school, we have lessons. What's the deal? Why do we have all of this? And the best reason is that we found that there were good research questions for almost every type of care we could think of. And so, for example, even the unpaid individual category sometimes may be purely a social child enrichment activity. Grandparents like to spend time with their grandchildren. But in other cases, that may be the primary arrangement that supports parental employment. And so we felt that it was important to be able to log when it was occurring so that researchers could come to the data with a variety of questions to try to uncover when is the non-parental care of value to study, of policy relevance to study, and when is it really a separate social phenomenon that maybe is not of interest in the ECE policy context. A similar example is, well, why don't you just look at care that takes place when the parents are working? Well, under that definition, many center-based arrangements, for example, Head Start, may be taking place when the parents aren't working. It seems, unthinkable that you could have study about early care and education and not accurately measure Head Start participation hours. So that's another example. And then even the irregular care that we see, we talk often about, well, that's might be Saturday night babysitting, so parents can have a date night. Why are we capturing that? Well, it's hard to know what is irregular care that it really is, maybe policy irrelevant, versus care that might be irregular because parents work irregular or unpredictable schedules, or for other reasons they may need to rely on irregular care for employment support. Our hope is that through the use of these data, people will be able to better classify different types of care, but on the face of it, we could identify really strong research questions for the inclusion of virtually everything that happens over the course of the week, so that we can actually, as a field, answer some of these questions about what's being used for employment support and other exposure for the children. Another question we get a lot is whether the household survey providers, so the providers that households report having used, whether they can be identified in the center-based and home-based data. And the answer is that researchers generally cannot find that overlap. We have tried to do it as a project team using the very confidential data, and the rate of overlap is extremely low, so that the research value at this point of making that connection is entirely unclear because there are so few providers that you can actually find in our sample, and that, of course, primarily comes from the fact that we sampled center-based and home-based providers. So we didn't collect information about every provider in a community. And then, in some cases, households may go outside of the community to find their care. That would be another reason that the overlap is low. And finally, a lot of the unlisted home-based care is, of course, not in the provider survey, unless by true coincidence. So that avenue of research is generally not available. Okay, so we have now kind of gone through the elements available in the household survey and how we as a project team have chosen to categorize the household arrangements. Those choices that we made are how a lot of the analytic products are made available, and the availability of created variables is much greater using our definitions than alternative definitions that you might come up with, but those elements are available for you to construct your own alternative definitions. I'm going to now move on to home-based or individual providers of ECE and talk about how these overlap and coincide between the household survey and the home-based provider survey. So this is a list of elements that you might be interested in about home-based or individual care and whether or not they are available in the NSECE data. Right off the bat, you'll see I'm wavering about the terminology. On the provider side, we talk about home-based providers of care, and as I said, we think about residential settings. For the household survey, we use the word individual because that is much clearer to parents and ordinary non-ECE language speakers. And so in the household survey, we always talked about individuals providing care. And so the household survey types of care and other measures use the term individual. When we're on the home-based provider side, we use the term home-based. They both describe care that's being provided in a residential setting. And you'll see the same kind of duality when we get to centers. So the first element is the appearance of a provider on a state or national list. That would include regulated, license exempt. There are many different ways in which somebody can appear on a state or national list of early care and education. That information is not at all available in the household survey about arrangements. However, it's the central platform for the home-based survey. And so this is one of the non-optional elements. We have a listed provider sample and an unlisted provider sample, and we do not encourage people to combine the two. There are a great deal of statistical issues when one combines the weights from the listed and the unlisted providers. And so although you probably don't want to distinguish them because there are many interesting policy questions for which one would like to combine listed and unlisted providers, it's generally statistically a bad idea. So the first element here is non-optional and applies only to the home-based survey side of the data. The next element is whether or not there was a prior personal relationship between the child and the provider. This is information that's available both in the household survey and the home-based provider survey, but for the household survey, this is a question about the child-provider pair, whereas in the home-based provider survey, we're talking about the full set of children that the home-based provider cares for, not just any individual child. And so this is true for all of the home-based items pretty much, that when in the household survey data, we're really only seeing how one individual provider pair, child-provider pair can be characterized. But on the home-based provider survey side, we're getting a summary characterization of the provider and all of the children that that provider might serve. This is a little bit easier to think about maybe in the next element, which is payment status. So payment status is really, on the household survey side, is the provider paid for caring for this child? On the home-based survey side, we're asking, is the home-based provider paid for the care of any child? And you can imagine a situation in which a home-based provider is paid for some children and not for other children, in which case the characterization from the household perspective would vary depending on which child we were talking about. From the provider perspective, she is paid for at least one child and therefore classified as a paid provider. Other characteristics could include familial relationship between the provider and the child, or whether or not they live in the same household. And again, that information is available at the arrangement level in the household survey data, but only in the aggregate for the provider. Another implication of aggregate numbers is that you can't decompose them fully. So we may be able to say in the home-based provider survey data, this provider is paid for at least one child that she serves, we may also, from the next element, be able to say this provider lives in the same household with at least one child that she serves. But because these are aggregate data, we may not be able to say whether the child she's paid for is also the one that she lives in the same household with, or whether those are two different children in her caseload that are contributing to the characterization of her care. So a first issue when you are trying to generate estimates that talk to one another across the household survey and home-based survey are that the household survey data speak only to the specific child provider pair, and the home-based survey data speak to the entire caseload, most of which may be unobserved by the household survey respondent or by the parent of any given child. That's another way to think of it. We also have information about hours and location of care, again, at different levels of aggregation in the household survey and the home-based survey, and then numbers and ages of children served, subsidy receipt. These are all concepts that are available, but at different levels of aggregation. For our purposes, we chose 3 analytic categories. In our work, the listed providers are all together. Everyone who comes from a state or national list is in a single category. There are almost 4,000 cases there. They sum to represent 121,000 providers. Virtually all of these are paid providers, not 100%, but virtually all. Then we have unlisted paid. So these are individuals who did not appear on a state or national list of home-based providers, and they are paid for at least one child. The majority of this group did have a prior relationship to the children that they serve, although not all. And this is a relatively small group of about 500 cases that represent 1 million home-based providers. This is a group that is of great analytic interest, and unfortunately this 535 case count is often a constraint in terms of what one can analyze. We'd like to know a lot more about these unlisted paid providers, and hopefully we will, based on the work that you all do. But often we're constrained in what types of analyses we can do with this group because they're relatively small in number. And then we have the unlisted unpaid, these providers who did not appear on any state or national list, and they're not paid for the care of any child. As I said, almost all of these have prior relationship to their children, and many, although not all, live in the same household. And here is where the weights are the largest. We have 1,500 of these cases, and they represent 4 million home-based providers. There are many other taxonomies that are possible. This is just the one that we've adopted and about which we've released a good bit of information.
We have a question about weights.
Okay.
Might be a good place. One participant asked if listed and unlisted home-based providers should not be combined. Why is there only one set of weights?
The weight, there is a single weight variable, but we encourage the use of the sample source variable, which distinguishes providers as being from the listed sample or the unlisted sample. And so we strongly encourage people to do all of their analyses, splitting apart the listed from the unlisted, We included it all in a single weight, really just so that to facilitate statistical analysis, you have to write less code if we use one variable, and you just can partition your analyses by listed and unlisted, but certainly another approach is to separate it into two separate variables if it's easier for analysts to use it that way. It's just the combination of the sample source variable with the weight variable that would yield that result. This is something that comes up all the time, so if my response is not satisfying or you still have other questions, please do resubmit them. This is probably one of the most common topics that we discuss with people. Do we have any other questions?
Not at the moment. It looks like somebody might be typing them.
Okay.
Oh, we do have it if you're ready.
Oh, okay.
So someone is advising on weights. So another participant says if you combine them in an analysis and use the weight variable for them, sorry.
Yeah, the statistical result is that the listed providers will have tiny weight and be dwarfed by the unlisted providers. And that's exactly right. Thanks, Nina. As you can see on the analysis category slide, the weights for the unlisted providers are very large. Roughly speaking, you can divide the weighted N by the number of cases, and that will tell you what the average weight is. And the average weight is almost 80 times as large for unlisted as for listed cases. And so the contribution of the listed providers basically gets deeply diminished if you combine the two sample sources. Okay, I'm going to spend a little bit more time talking about these analysis categories that we've adopted, but again, you don't have to adopt them. These are the ones that we've adopted, and especially because the listed and unlisted, of course, is totally unnatural and nobody would ever come up with it. It's probably useful to think a little bit about these definitions that we've chosen, if only to increase your comfort level with the distinctions between listed and unlisted, which, as I said, are not optional and you're stuck with them with these data, however else you choose to classify types of care. And so for listed, we often think about licensed care, and certainly licensed providers are in the listed group, but there are many other providers as well who are on state and national lists but not licensed. And this would, for example, include licensed exempt, regulated, and many other categories of that type. Another thing to keep in mind, going back to the issue of characterizing an entire caseload, but if you had an example of a grandmother who cared for her own grandchild and who also operated a licensed family daycare home, from the household perspective, that might be even an unpaid arrangement with a prior personal relationship, But in the home-based data, because she is a licensed family daycare home operator, she is a listed provider. And that is where her data would reside, would be in the listed sample, and we would see that she might be caring for a relative, perhaps even that she's caring for someone without pay. But she would be showing up in the listed sample in the home-based data. Among the unlisted paid categories, so these are any individuals who did not appear on the state and administrative lists but are paid for their care, that may or may not be somebody with a prior personal relationship. So, for example, a nanny would likely not have a prior personal relationship with the family, but would be unlisted and would be paid. Another type of paid unlisted provider could be somebody receiving a subsidy payment for providing care to a family member, or a neighbor who regularly provides paid care. These are still regular arrangements, so at least 5 hours weekly. And then we have unlisted, unpaid. These are almost all prior personal relationships, but could be, for example, an adult sibling who lives in the same household as younger sibling children and cares for them for free at least 5 hours a week, or a child's aunt who cares for the child after school in the aunt's own home. So there's no requirement that they live in the same place or that the care be in one place or another, just that the care is regular and unpaid. We can also think of it in reverse, which is there's some common terms that we see in the literature and in practice, and where would those fall? And unfortunately, the answer is almost always, well, it depends. And that shows how complex home-based care is and how difficult it is to come up with clean categories. So family child care providers, I think we had a question sort of about, is that go in the home-based category? And for sure it goes in home-based, but a family child care provider may be listed or unlisted depending on the state's requirements and whether or not the provider has sought, licensing, for example, if that's appropriate in her state. And so the family child care provider, depending on how you define it, you might have to go look for those providers in both listed and unlisted paid portions of the sample. Another example would be a grandmother caring for a grandchild who does not live with her. And again, that person could show up in different places. She could be unlisted paid or unlisted unpaid, and the payment could either be from the family directly or, for example, through a subsidy. The category family, friend, and neighbor is very common. And again, the family, friend, and neighbor really can be anything depending on the payment status of the children in care and whether or not the provider appears in state administrative lists. We have found, for example, that in low-income communities, in fact, a lot of the listed care is provided to children with whom there was a prior personal relationship. And so there's a great deal of mixing and matching, and it's difficult to make these, to impose some of the common definitions in the field into these data. And I would argue that's because the data reflect the complexity in real life that we just now have better measures of. Okay, I think we've basically covered most of this. The household survey categories are arrangement specific, so they pertain to a child provider pair. The home-based provider survey categories are provider level, so they describe all of the children in a provider's care and the summaries of those children. And as an example, a child can receive unpaid care from a provider, and so in the household survey, that looks like unpaid individual care. But if that provider is paid to care for other children, then in the home-based provider data, that person would be showing up as, let's say, an unlisted paid provider, even though some of the children she's caring for may be unpaid. So there are a lot of cautions to thinking about how to align these categories. Looking at the household survey categories in the aggregated types of care that I showed you before, there are 3 main household survey types of care that we use: individual, no prior relationship paid, individual prior relationship paid, so one is no prior and one is prior, did have a prior, and then individual unpaid. And if there were only one child in the arrangement, so if the provider cared for only one child, even in that case, the only category that we can match directly is individual unpaid to individual unpaid. Those two groups would match exactly. For the two paid categories, the household survey, two paid categories, individual with no prior relationship and individual with a prior relationship, there's no direct match between those and the two paid categories on the home-based provider side, listed and unlisted paid. That depends on the status of the provider. And so anytime you're making estimates from both sides and trying to compare or contrast them, you'll want to be very careful about these mismatches, potential mismatches. Okay, that's the end of, not the end of home-based care, but the end of our slides about that topic, and we haven't received any.
Anne asked a follow-up question about the dwarfing of the listed by the unlisted.
I think that it would be useful to keep going, and then perhaps when we get to the research questions and further discussion, we could return to that topic, or maybe we need another discussion about that.
Sure.
Thank you. Okay, so now we're going for center-based or organizational providers of EC. And again, this is a situation where on the provider side, we use the terminology center-based. And for households, we asked about organizational providers of care because that was the more appropriate language for household respondents. And that's the first sort of point of difference between the two. So just quickly going over the center-based provider sampling, we began from the state and national lists of centers providing care. We looked for centers that were listed as serving children 0 to 5, as well as centers that were listed as serving school-age children, but when we contacted them, they confirmed for us that they were serving children 0 to 5. Also in that category would go elementary schools, whom we also contacted and who could have told us that they were serving children 0 to 5. In addition, the program needed to be enrollment-based as opposed to drop-in. It needed to provide services at least 3 days a week and 2 hours per day, not necessarily to the same child, but they needed to be open those hours, without providing residential care. So it says no nights. What we mean is that it can't be a residential program. And then it must be a multiple activity program. Single activity centers are not eligible for the center-based providers. So having identified these eligible programs, again, those are the programs that served at least one child, age 5 or under, not yet in kindergarten. Among that group, we then asked questions about all their services to children under age 13. And we specified that these should be provided by a single organization at a single location. And so that's relevant because what we did was we sampled an address. And it's possible to have an address where multiple organizations are providing ECE. This seems crazy, but you can imagine, for example, an elementary school that has its own pre-K program as well as rents space to a private preschool. In that case, you have 2 different organizations providing care, and we would have sampled one of them. And if that organization happens to have multiple sites where they provide care, we only want to know about one physical location. In addition, you may be, in this definition, getting multiple activities within that one organization at that one location, like both a Head Start program and an after school. The center-based respondent was the director or instructional leader who would have been knowledgeable about staffing and enrollment of the early care and education activities. Just to give you a sense of how broad this universe is, we typically think of a director in a standalone preschool. Maybe she has a clipboard. But we also might have something like a YMCA that also has a gym and maybe a residential facility and a preschool, in which case the person we would have wanted to talk to would be maybe the coordinator of the early childhood education programs in that facility. We typically would not have talked to the director of the whole place who was also managing the gym and the hotel. In an elementary school where the whole of the ECE is a pre-K classroom or two pre-K classrooms, we might have sought to talk to the pre-K lead teacher or somebody like that who was responsible for the pre-K activities. And then in the case of a multi-site program where there were many different facilities operated by a single program, we would have most likely sought to talk to somebody like a site director, somebody who's responsible for the ECE at the sampled address, even if the title of director might have been belonged to somebody in a home office somewhere. So when we think about mapping the household survey types of care to the center-based provider survey, this is super easy. Aggregate type of care 4 in the household survey, center-based early care and education, maps exactly to the sample of the center-based provider survey. So that is a one-on-one match. The various kinds of organizational care in the aggregate type of care 5, other organizational ECE, that included the school-age care, drop-in care, single activity. All of those things were ineligible for the center-based provider survey. The one sort of footnote there is that centers in the center-based provider survey had to serve children 0 to 5, but they may also have served school-age children, and in that case, some of their information about their school-age care is represented in the data. For example, their enrollment numbers, and a school-age worker might have been sampled for the workforce survey. But you would not be able to make that connection between the household and the center-based, because when we collect after-school care in the household survey, we are not generally able to tell if it is in a facility that also has children under kindergarten, not yet in kindergarten. So there is a detailed type of care category in the household survey, and here are the categories that fall there. Aggregate type of care 4, which is the one that maps to the center-based provider sample, includes these categories 23, 24, 25, and 27, which enumerate different funding streams, basically, and community-based childcare is sometimes thought of as an alternative to Head Start and public pre-K. The elementary school aggregate type 6 maps exactly to one of the detailed types of care, category 26. And then category 5, other organizational ECE, basically includes all of the different ways that an organization could have failed to qualify for center-based ECE. This is all on the household survey side, but it helps you think about perhaps some of the nuances that you might try to delve into if you were going to build your own type of care frame. And I will say that we've spent much more time and attention on the younger children And so there are probably more easily done, very sensible things on the school age side that we haven't gotten to, whereas we've thought long and hard about most of these issues on the on the younger children's side. Okay, so I was going to wade into Head Start and pre-K. So if we wanted to know more about Head Start and public pre-K, where could we find information within the NSECE data? So in the first stage, when we built our sample frame, among the state and national lists that we drew from were the Office of Head Start list nationally of every Head Start address. And that is a very high quality list that we have found throughout data collection to repeatedly be confirmed and validated. We also collected pre-K rolls from every state Department of Education where there was one available, and from some of the largest school districts within the sample. And so from our sample frame data, we know which addresses were listed in administrative records as providing Head Start or public pre-K, or both. Then when we selected the sample, we oversampled addresses that were listed as having a Head Start or public pre-K to ensure that we would have enough sample from those types of locations which are of high policy interest. Having selected the sample, we then did a screening in which we confirmed the information that we had from administrative lists, confirmed eligibility for the center-based provider study, and where necessary sampled an organization that was providing care if there were multiple. At that time, we confirmed the existence of Head Start and pre-K within the location, as well as added information that we might not have received elsewhere. The centers that passed that stage and were deemed eligible and sampled were then asked to complete the center-based provider questionnaire, where we further ask about sponsorship, about sources of revenue, and about enrollment funded by Head Start and public pre-K, among other public programs. And so there are also data within the center-based provider questionnaire about these programs on the center side. We, in turn, loaded the sample frame from the first bullet into the household survey interview, as I described, and used that information to classify providers that households reported receiving care from. And finally, in both the household survey and the center-based provider survey, we have created a range of variables that include both direct reports as well as various kinds of analytical estimates of our assessment of which respondents, which organizations or individuals are likely to be receiving Head Start or public pre-K. As I mentioned, the sample frame included information from a variety of types of lists which may have told us about Head Start or pre-K. The biggest thing to understand is that at the screening phase, we identified a very large number of new public pre-K programs that had not been reported in any of our lists. So we knew from the lists that those locations had early childhood, but they had not been indicated as public pre-K sites. This is important partly for the center-based side, because it means that our sample frame data for the centers are not as reliable about pre-K participation. But it's actually far more relevant for the household survey, because we had relied in part on the quality of the sample frame to help us identify pre-K participation of children. And what we know is that the sample frame that we had available during the household survey is actually not very reliable about identifying pre-K programs. It's quite good at Head Start programs, but it's not very good at telling us which programs have pre-K. We found both that new programs had pre-K that did not, were not so indicated in our sample frame files, and we also found a lot of programs that were marked as pre-K that didn't report any pre-K. And so the pre-K indicators from the sampling frame that we have available in the household survey are quite limited in quality. And I'll get to which variables in particular that means. For the center-based provider questionnaire, we have enrollment-related data, funding data, and so within our sample of centers, our ability to identify centers receiving some Head Start or state pre-K we're actually pretty comfortable with, and they seem to match program estimates fairly well. For the household survey side, as I mentioned, we used the sample frame as a provider lookup to gather information about the types of care that were available at a given address. We also used age of child, cost of care, schedule, and household income information to make our best assessments of the type of care that children might be enrolled in. So when we think about alignment, what we have in the center data are centers who serve at least one child whose enrollment is paid by Head Start or public pre-K. And those are two separate variables, Head Start and public pre-K. But the center has at least one child. It's not that everyone in that center is funded by Head Start or public pre-K. It might be, but what we're best able to report is that the center has at least one child. And we see actually that there's a great deal of variability in how much of the EC provided by a center is covered by these funding streams. On the household survey side, we are able to say which children receive free center-based care, so their parents don't pay anything out of pocket for their center-based enrollment. And then we can report whether the child attended a center that was listed as receiving Head Start funds or public pre-K funds. For Head Start funds, as I mentioned, the quality of our lists are quite good. So if a child attended a center listed as receiving Head Start funds, then it's a pretty good guess that the child attends a center that actually does receive Head Start funds, and so would, for example, meet the definition that we use in the center. This center serves at least one child whose enrollment is paid by Head Start. For public pre-K, the value of knowing that a child attended a center that was listed as receiving public pre-K is much more limited because the quality of those initial public pre-K lists was more limited, as we described. And we do have a technical appendix to one of our reports that we've released on which centers participate in Head Start and pre-K, and that technical appendix gives more information about how we define Head Start and pre-K and what some of the limitations are of those data. So in the center-based data, we have two variables marked self-reported Head Start flag and self-reported pre-K flag, and these are our best approximations at which centers have at least one child funded by these streams. In the household survey, you can look at these type of care variables at the arrangement level. And although there are also detailed types of cares, the ones that I showed before that say it's an organization that's regular and Head Start, or an organization that's regular and public pre-K. We don't actually advise putting too much faith in those variables, especially not the public pre-K one. However, we have a series of variables that are included. I'm sorry, I misspoke. The detailed TOC variables are based only on what the household told us and whether or not we were able to corroborate it. So that would be a case in which the household said, my child is in pre-K at this address. And if we were able to confirm that there was a pre-K there, we marked it as such. We have also included an additional set of variables, and you might see provider address type is kind of what's embedded in this variable name. And then provider QED type refers to a commercial database we use. These variables describe what other care is available at the provider's location. Here again, we're limited in the pre-K data by the fact that the pre-K lists were not that great, but we have information. The Qs refer to different licensing types. So before, after school, Head Start, pre-K, Head Start and pre-K, elementary school only. There were a variety of licensing sources, and that's the information that's available in these provider address type variables, which we feel as a first step applying these to the detailed summary variables immensely improves the quality of the Head Start indicators and at least modestly improves the pre-K variables. I am sorry, it looks like we had a time confusion, so we have gone a little bit over, but we had just gotten through the material, the main material, and then what we had left were some research questions, which, as Brian mentioned, will be available online. They cover things about how schedules, cost, choice of care, and supply and demand can all be studied by pulling together the various NSECE data sets into a single analysis. But we encourage you to consult the NSECE resources page for a great deal of information about the NSECE. You're also welcome to email us with questions. We appreciate your staying with us, and we hope to talk with you in the future. Thank you.